is our uterus that goes in there sometimes, but we're not doing that today. So, none of you guys are scrub techs, but you are in the ORs. Yeah. As a circulator, as a whatever, okay.
Whatever.
Okay, so
Usually circulator.
you can look at this, anybody can do this to help. There's one easy thing, it comes like this, is sterile, so it can get put on this, it can be opened, the box, it's a peel pack, and you can plop it on the sterile field.
Okay.
Okay, and then, any kind of saline is good, warmed up, whatever.
Oh,
So
it's right down there in the cupboard.
Oh, we got
It says
one.
Ambridge kit. Okay, thank you. It's right in there.
Oh, where they
And that's
live.
the whole,
There
everything,
it is, right
everything
there.
to do with it is right there.
Yep. Yep.
Don't be open my seal though.
So anything you need for that
Doesn't expire till
delivery.
December.
Okay. So it comes like this, so the scrub tech would take this off, set it down, with this, get it out of the way. There's an instruction thing here so you can sort of see what it looks like and what their recommendations are, that we brought, but it does come with these instructions
So
and
this
has
has to be done in surgery in the OR?
No, it can be done in the ED as well.
Okay.
It could be done here. So if you've got somebody who comes in with postpartum hemorrhage, bleeding like snake, you know you're not gonna hang on to her and you're not bringing her to this room. All this can be done in the ED.
Okay.
It can be done anywhere, they just have to leave once they get it, right?
Right.
Yeah.
We don't want them here.
You do not want them here. So any timing on this is usually once you've tried a full round of the meds and they're still bleeding. So a sweep, so if you go in and do a manual sweep to make sure if you can get into, this is a very patent cervix, so you could do that. So I'm gonna pretend this is sterile field. I like to have a couple of ring forceps, and because most cervix isn't this widely dilated and maybe angled posteriorly. So if you can just clamp with this, it doesn't really hurt, and just even tip it a little bit. Pushing this in is super easy. You can push it in by hand, with sterile gloves, of course, or with a ring right on the edge of this, but not compressing it fully. So you slide it in like that. And speculum is the easiest way to do it, where you can, put a speculum in, grasp this, visualize exactly where it's going. When you put it in, your job is to hold it in there till at least has about 300, 350 mLs in it, because otherwise it wants to come out, because we've been giving all these uterotonics to try to make the uterus contract. And the uterus may want to spit it out. We want to insert it so that we can feel the fundus, so up to the fundus maybe, and then back off a little bit so it will fill the whole cavity. And then what the important things are before we do this is that the scrub tech gets this set up so it's ready to go. So, you can be doing your exam and all of that stuff, and while you're doing your exam, this can be set up. So the secret on this is there's a one-way valve that only works if you hook it up right. So red to red. The only things that have that, the only connector with a color, even if you're colorblind, none of the connectors have a color other than the blue stopcock, but it's not a connector. So, and I have this closed right now to keep air out of this, but it comes like that, and it stays like that until we're totally done filling. You don't have to turn it on and off, because the way the one-way valve works. When you get red to red, you can't connect it wrong, because that doesn't fit there. It fits here. There's no way. There's only one thing for each side. And the same with this. This only goes on the screw in on this end. So we've got now a tube. We've got now a balloon. And we would have spiked the bag probably before we had this all set up. So I'll show you why, because,
So this would be spiked first.
yes. So
And the
that would be
tubing would be
typically
and
spiked
primed
first.
or-
And primed. Well, it's just, once you spike it, so I'll show you, let me disconnect it from here. Be the easiest maybe. Okay, so you're gonna just let it run so that we know that we've got fluid all the way in it. You can squeeze it if you want to.
I think need to push a little bit in here. So while your doctor is inserting it, the assistant is taking care of spiking and getting the tube ready to go.
it not, is
You
it,
maybe have to pull on the plunger.
Up higher, maybe.
I think you need to push a little bit more on that,
It should run through, but I can push on the plunger, but there we go. Okay, so now it's
I
flush.
think it's because I think you have to unconnect it from that, there.
There you go.
Yeah, your head pressure.
So, then this is hooked up to this, once you know that there's no air in the line. That you don't want, and, sorry, let me just, I had to unsqueeze it. Well, these will come, when it comes fresh out of the package, it's flat, it doesn't wanna get air in it, it's just cause we've used it so many times. So, and, you know, these don't blow up very often, but they can, they're single use, and occasionally somebody will overfill and they'll pop, so you don't want air in there, cause it's not good to have air in the uterus. So, we're gonna say you put this in with your sterile hands, with your sterile gloves or your other gloves, and yep, just thread it in like that, and you're in, and then you can tell me when it's okay, and you're just gonna stabilize it, and then I'm the scrub tech, and you can either hold that and squeeze it, cause it does fill it a little quicker, or you can just set it off someplace.
This would be us in the ER, right?
This be us in the, you guys in the
Yeah.
ER, it'd be in the OR,
or
right?
no.
It's usually the scrub tech that's doing this, so I'm putting in 60 mLs now. And
So
if there's a
someone-
third person in the room, they're writing it down, okay? And I'm gonna
60.
pull, 60's in, or you can say one full syringe is in, or whatever, 50,
And so that's a
60.
one-way,
It's
it's,
a
it's
one
a one-way
way valve, you
Yeah.
just pull and push,
Pull and
it's
push,
really
okay.
easy, closed
That's nice.
system, yeah, really
How
nice.
many mils?
And it takes a little effort, and I'm pushing another one in. So that's
3 to 5.
number 2, that's 120,
120,
right? So if you
recorder,
can't
yeah.
add, at least say it's been, this is the third syringe and it's a full one. We've used this so much, we've worn the numbers off. Anybody wanna pull this? One of the nurses wanna pull
I'll
it?
try.
Cassandra wants to pull it, cause she loves getting in here, I
I
love
do.
this. So, nursing school on the list for Cassandra, I think.
Someday.
Uh-huh.
So that's when it would be full, right?
Yeah, all the way, yep, and then you're
And
pushing
then-
it in, and that's number 3.
Number
Third
3
full
going in.
syringe in.
Yeah,
and how many do you put?
Minimum of 300.
minimum of 6 of these.
Yeah, so 300 cc.
300, 360. And then how you know is, I mean, if you have a portable ultrasound, you can take a look at this picture and you'll see that there's no space at the top of the balloon. If not, and you don't need to be good at ultrasound, it's, you know, it just looks like a big
So
round
the,
thing in there.
someone knows how to look at it though?
And otherwise, when the bleeding
So that's number 4.
ceases, and you've at least got 350 in, you can
Okay.
stop, or you can just, if you're here and you wanna just fill it to
Just
dry.
hold
You
it
know,
as
when
high as you
on a
can.
small uterus, you might not
Not
get
gonna be
5
my
in.
job, I promise.
And if you stop
This is
and
number 5.
Okay,
if you stopped and then you noted
Yeah,
bleeding
this
again,
will
you
be
could
the
add
last
more.
one.
yes,
Potentially, this
A little
would
bit
be
of
the last
gravity,
one.
but I think.
yeah.
Holy
Up to 500, right?
You got
You
muscles.
can skip,
Up to
skip your
500.
forearm
But this
workout
says
after
the
this.
maximum balloon volume is 500
500,
cc's.
yeah.
Yeah.
So
So that'd be 9, not doing more than 9 of
This
those.
is 300.
Yeah.
Oh, wait,
Yeah,
yeah.
then you can look at your bag too and see,
Oh,
okay,
yeah, there we go.
we've used that as a double check, but you always wanna know how many mLs you're putting in, you always wanna know, okay, so you can see now that that's not
Not
gonna
gonna
fall
fall
out.
out.
Right, right? So,
so it's putting pressure
Oh, yeah,
on
that's-
the
even though her
inside,
cervix
on the
is like,
uterus.
you know,
Yeah, you're kind of
5 or
on
6
the
centimeters
vessels.
out there, it's not gonna wear.
Same idea as the esophagus
But
one.
there's room in there, so this uterus really could have probably taken more. We won't
Same
do
idea
more,
as what?
but- Yeah.
Same.
The esophagus one.
Yeah. So they started out using the St. Stockholm Blake Mark tubes for this, but the shape is a little bit more, you know, hot dog shaped, and for the esophagus, which is what it was designed for, and these really fill the uterine cavity a little
Hot
bit
dogs
better.
started this problem.
And this is a super easy hookup. They've modified this to be, you know, a closed system instead of the open, fill it out of a tub before. And then you do wanna shut this valve when you disconnect it, because otherwise it leaks all over. And then I just put a gauze around it and just tape it to the leg.
And then they're
How long
off
do
the
you leave it
ambulance.
And they're off in the ambulance, that's right.
And-
Even if she's still bleeding, leave it in. This
Yeah.
gets hooked to a Foley because there's little holes at the tip or just below the tip that would allow you to watch how much blood is still happening. Yeah, yeah.
So just a
Oh,
regular
there's a
Foley
side
thing.
It's a regular Foley.
Yeah, right.
That seems like
Oh,
that
sorry,
would want
just
to
a
go with
typical
you
Foley
because
entry.
if you're
Yeah.
leaving.
So it's just a collecting
Is it
thing.
an end hole or something?
They're up at the very tip there.
It's an end,
Yeah.
must be
Yeah.
an end hole.
Yeah.
Is there any way
Kinda
you
like
could
an
like
element.
kill the uterus or something if something went bad? Is there any bad things that could happen?
Gangrene.
No?
If the
You
bag bursts,
You leave it, the bag bursts, and
If
you
like
have
if
to
there's
find
too
the
much
pieces.
pressure, does it
Yeah, if you.
cut
if
off
you-
circulation or
No,
anything?
No.
You hope it does.
Yeah.
Well,
want
you
it-
know what I mean.
You want, you
To
know,
the uterus.
you're trying
not-
to tamponade those open
Yeah.
arterioles and still have your uterotonics going, so, I mean, this one is not gonna be left here, but if she were here, we don't do fundal massage, but we do fundal heights.
Mhm.
Because increasing fundal heights is a sign that clots are forming behind this. Also, it's super painful. I've seen one patient actively doing that. We didn't realize it at the time, early in our use, where she was forming clots behind and she was having incredibly painful contractions with the balloon in place. And that's because that was, expanding and she was still bleeding.
so
yeah.
once they get her wherever, they would take this out and go in and do
A
a
DNC.
DNC.
Maybe or maybe not. If she's not bleeding, I would leave it alone.
Okay.
And they leave it in for 24 hours. Dose of antibiotics, so a dose of, 2 grams of Capsol or something like that is a one time. And document what you put in, right? So if you put this in and it felt a little like you were worried about the cervix and it coming out, you can do packing in the vagina. Make sure you document that all over the place. Make sure it's in the nurse's notes and the provider notes. It's really easy to leave packing in there. You think, oh, really? But when you empty this, you're gonna let it drain out and then you just slide this out. You don't do a pelvic exam because you don't wanna stir things up. So we've seen packs, left,
in there.
yeah. And people don't like that.
No.
No, and neither does the regulatory agencies. Yeah, they're really not happy about that. I'm like, you just saved your life, the pack didn't hurt her, doesn't matter. So this just drains into some kind of a graduated container where you can keep an eye on it. But I'll show you what the tip looks like, if you wanna see what the top of it looks like. So it is cool, and the published literature, we did, Swedish and the U did a practical thing when it first came out of what's our success rates, and our success rate was lower than what had been published, was 67%, and that was before we were using ultrasound and before we were filling it appropriately. So, because we were doing that, pull it and switch it out and all the stopcock stuff, a lot of times people would quit when the bleeding slowed down instead of filling it up to that minimum of 350, yeah. And I still see people say, oh, well, it's just the lower uterine segment that's boggy. Well, fill the whole uterus, because if the, it's not gonna tamponade the stuff in the
It's not gonna
top,
hurt
yeah.
Physics says
Yeah.
you need the whole space
Right,
filled.
right. So yes, so you're in the ED, this patient's bleeding, you've given her oxytocin, methogen, hemabate, maybe you put rectal meso in as well. You're not gonna put oral in somebody who's tanking, because then if she has to be intubated, it's not good to have that. It's, it's a antacid, so it's meant to be dissolved in gastric acid. So if you put it in the mouth for sublingual, it's this chalky stuff that stays for a long time. So, so you can see as this empties, and then, you would empty it before, I'm gonna pull it out a little bit here so you can see what it looks like. So the top is these little tiny perforations, and they'll bleed out of here if there's still ongoing bleeding. Yeah. And you can flush this, again, that's not something probably you'd be dealing with. You can flush it if you need to, if you think maybe it's clotted up. Yeah, you just do it like once or two.
Like a Foley.
Yeah, so I'll get rid of this, but, and I want anybody who wants hands-on with that preventative maneuver to try it, but I just wanna make sure that you can
Thanks.
see how cool this is.
Yeah.
So-
Yeah. Yeah.
Why
So-
did you even ask?
When you look at the studies with it, getting used in a timely fashion, yeah, it's gonna be that.
Is that water or gel?
Used in a timely fashion and used with ultrasound guidance and filled appropriately, it's about 90% effective, so it's amazing, yeah. It can save uteruses. Yeah, it's way easier than you
Yeah,
think.
no, it is.
Yep, yep.
Okay, ladies, who's next here?
I'm
right here.
Oh, God.
You know what?
Let's get this thing, so.
Now, Dr. Walkoff and Dr. Flowers are OB doctors.
So, you know,
I just graduated. You are graduated.
Third or fourth degree tear, cervical tear.
Okay, so basically, this is a mom who usually maybe a multi or doing a precipitous delivery, right? Because then your doctor is not here in time. And so now I'm
And you're
crowning.
stuck with the OR nurse.
Yeah.
Okay.
Oh, I'm so glad that we have a nurse. And I'm not doing this alone. So basically, hold on for a second. So let's see, I want to feel, where am I here? Usually labor nurse, right? We say, oh, the head is out, is it? Okay, you want to touch, right? Sometimes we say that to them. Okay, so basically I'm crowning.
And they say no.
Okay.
Alright, so I start down at the bottom,
Okay,
right?
so
And
yeah,
then I
okay,
move-
posteriorly, again, the reason for that is this all tissue is stretchable, you can go all together.
It's just the fingers and not the thumb,
Yeah,
right?
fingers. So now I'm pushing because I'm uncontrollably pushing. Or you can talk to me. Look at my face and say, if you want me to breathe or something like that.
Nope, not yet.
Okay.
You're just holding it
No,
there
okay.
until the head, when the head comes out,
Then I
then
can
you
go.
go.
Yeah, so I am pushing here, right? You're not
so you're
doing
doing
any rotation.
Don't do anything, yeah.
Okay, so now I'm pushing, right? My head is coming out. I mean, my head, my baby's. So where are your fingers? I cannot feel your fingers. So
Now go
come
ahead and
towards.
sweep
You're
your
gonna
hand up.
try to feel the top of the shoulder, the anterior. Like feel my finger. Okay, not on the bottom now. You're gonna go. So from the bottom, your fingers will come. There
Okay,
you go.
so
Okay, right?
now I
I
can.
can my hand
All
in
fingers
there.
up there. No, not too far. Not too far.
Your fingers are behind the
The
shoulder.
top of the shoulder. There you go. Right there, right? So now I'm pushing, and you're gonna stop this baby said, because I'm gonna try to kind of push towards you, but you're blocking, right? You feel that blocking? Okay, you feel that blocking. So now I'm pushing, and now you're gonna push the head, I mean the shoulder towards that side. Okay, now I'm
Where are
coming.
the evals?
Oh, right there, please.